Hello, this is John Canelopoulos here in our office in Athens, Greece, clinical professor of ophthalmology at NYU Medical School in New York. I'm going to share with you an interesting case how even in eyes that have very regular cornea, such as a uh, lady that has suffered from herpetic disease with significant scarring of the cornea, can undergo with careful calculation a very successful cataract procedure that can also take into account the irregular astigmatism that this patient have and accomplish very good uncorrected postoperative refractive errors. We're going to talk a little bit about the which formula we use, and this is we're going to see this in the presentation in a few minutes. We decided to go Hofer Q here due to the fact that the anterior chamber is very shallow, and that's our go-to formula with a shallow anterior chamber. And how we analyze the irregular astigmatism with Fourier analysis in order to better isolate the regular part of the astigmatism of this patient. Well, without further ado, I will go in and narrate to you the actual calculations and the procedure itself, and thank you in advance for your attention to this very interesting case. Thanks so much. So this is the right eye of the case in hand. We can see the inferotemporal significant scarring from the herpetic disease, the cataract itself, and our 6 o'clock mark. The endothelial cell count on this eye was good. We're going to go through our standard pre-cataract evaluations, and this is the Sine-Fluke pentagon map showing the significant flattening at the area of the herpetic scar and across the field steepening, and this is how the cornea changed through the years. We have a previous picture, and these are the 5mm refractive data from total cornea aberrations. This is the placido disc reflection topography. And we're going to go look at the Fourier analysis in trying to better understand what's the real astigmatism. And the bottom left image shows the regular astigmatism, which coincides with our LaserVision measurements that define the cylinder at 82 degrees. So I mentioned previously that these are the LaserVision keratometers that we used. 88 on the LaserVision with adjustment for our incision, which is 135 degrees. The actual implantation axis was defined to be 82 degrees. We're going to see here the Hofer Q formula that we used here, and also a target of myopia. This was the non-dominant eye. We aimed for metropia in the other eye, and this is the Alcon Arcosoft spheric toric IOL calculator with our given target for 82 degrees. Here with our pictures from surgery, we use the 6 o'clock mark for the 90 degrees, and then define the 82, 275 keratome for our main incision at 135 degrees, and then using the same keratome for just the 1mm paracentesis. We can see that the two challenges here is, number one, the pupil is not dilating a whole lot. Number two, we know we're going to run into some problems with the capsulorhexis at the area of the scarring. So thus, first epinephrine, and we'll see a very nice response of the pupil once the mydriatic is introduced intracamerally, and then we will use air after we get sufficient dilatation of the pupil in order to use blue dye and define better the anterior capsule, because once we get to that quad of the very fuzzy cornea, we will have difficulty visualizing our capsulorhexis front. So we will go to our air introduction to the anterior chamber, which we can see here, and we do this in order to avoid the toxicity of the contact of the blue dye with the endothelial surface, an extra measure to protect endothelium. We are going to leave the dye in for a few seconds, and then go in with viscoat to fill the anterior chamber to help us with the capsulorhexis and the dilatation, fluid dilatation of pupil, and also protection of the endothelial surface. And we see that this removed most of the blue dye from the anterior chamber. Only the incisions are colored, and obviously the anterior capsule. It is known fact that this also makes the anterior capsule a little bit more rigid and easier for the cataract is something that we'll see here in the incision of the anterior capsule, slicing it with cystotome, and then commencing the curvilinear capsulorhexis. This is a relatively young patient for cataract surgery, 63. Our average in our center for Greek patients is closer to 73. So maybe a decade earlier. We know that it's not just the corticosteroid use in this eye that has suffered from herpetic disease, because we're performing the same day cataract procedure in the other eye as well. And we can see how nicely I can visualize now the anterior capsule going in with the intraocular forceps, grasp the edge, and we'll run mostly for our younger colleagues who are beginners in the procedure with a continuous curvilinear capsulorhexis, step by step. This part would be very comfortably performed without the use of dye, and I performed the procedures with a short term peribulbar anesthesia. Use 5 cc's of 2% xylocaine diluted with 5 cc's of balanced salt solution. I'm grasping here, and we're already seeing the difficulty in visualization right under the herpetic scar. But once I get a nice edge under my utrata forceps, which I accomplish here, I can use the blue dye as a guide even through the very hazy part of the cornea to help me complete my capsulorhexis uneventfully. I was talking about my short-lived peribulbar anesthesia. Usually it resolves within an hour, so by the time we perform the peribulbar anesthesia, we perform the surgery, the patient goes to rehab for about half hour, something to eat, replenish fluids, and by that time the eyelids are open, there's full movement of the eye, and they can go home with their eyes open. So during the procedure we have maximum compliance from the patient, because there's no movement, there's no feeling at all, there's no pressure. We talked about before that this is a shallow chamber. The actual anterior chamber in this patient is 2.3 millimeters. So despite the peribulbar anesthesia, we also use some intravenous mannitol here to reduce the vitreous volume and creates a very nice, and as you can see, quote-unquote flexible environment. We dissected the lens in 2 halves, and now I'm picking up with, this is the signature White Star probe, higher aspiration, only 10% phaco power. We're picking up the first hemimeridian of the cataract to go on then and spin the other half of the cataract after we refill the anterior chamber with viscoat. We can see here rotating the other half of the cataract and picking up the other half of the lens, and completing our phaco emulsification of the cataract nucleus. Again, we're at the pupillary aperture level, away from the cornea and away from the posterior capsule. We're a little dancing around from the nucleus, so this is where I will always, and without second thought, refill the chamber with visco to enlarge my capsule back, push back the posterior capsule as far as possible from the level that we're working, and thus reduce the possibility of it being entrapped to my phaco tip. Also stabilize the nucleus that I'm emulsifying at this point. And third, get a better dilatation of the pupil. And we can all appreciate the higher stability that this accomplished in the anterior chamber. We're basically done. A small fragment left behind, absorbed, and jumping into irrigation aspiration. In second step, again, the coloring of the anterior capsule with the blue dye will help us in this aspect as well. And we will go directly into performing irrigation aspiration in order to clear all the cortical remnants. We have finished the first half, and now with using aspiration and by manual fashion through the paracentesis, we're completing the clearing of the capsule bag. We'll fill with methylcellulose here, not viscoat, as we just need enlarged space, especially in this shallow chamber eye, to uneventfully place the lens we talked about before. The power was confirmed by the Fourier analysis of the topography, but basically based on the lens toric keratometry measurements, which surveyed the central 2.8 to 3.2 millimeter circle in the vertex of the cornea. We're picking up our spheric toric IOL with aim of 1 diopter, 0.25 of myopia. Our fudge factor for this lens is about half a diopter, so if we aimed for plano, we would put half diopter stronger lens power than the Huffer Q formula would produce for us. So the cartridge enabled us to implant this beautiful lens. We've been adapting with the toric IOL back in 2006, and we might hold an international record currently, as 95% of our patients do enjoy the implantation of the toric IOL in our practice. I feel very strongly about leaving the eyes at most half a diopter with the rule. So even if we encounter a patient that's half a diopter against the rule, I will invariably try and switch that to a mild with the rule astigmatism. And outside the US, we have the ability to use a T2 lens that has a low amount of astigmatism and complete this refractive target of emetropia, and with zero or if anything a slight with the rule astigmatism I'm using here after hydrating the incisions and accomplishing watertight anterior chamber, recentering the lens to the exact markings that we placed for the 82 degrees, and using myoclone acetylcholine to attain meiosis and trap the lens and the capture bag behind the iris. Our procedure is done. This is the next day. We can see the scar that we sidestep, a nice small pupil, and the patient is enjoying uncorrected 20/25. Uncorrected 20/40 vision, best corrected 20/25, and how the vision has improved dramatically with the help of successful cataract surgery. Thanks so much for your attention.